In this lecture, we will discuss Wolff-Parkinson-White or WPW syndrome, including its pathophysiology and EKG features. Wolff-Parkinson-White or WPW syndrome is a ventricular preexcitation syndrome that results from a bypass tract known as Kent bundle or the bundle of Kent. Now this Kent bundle connects the atria to the ventricles. So if you look here, we have this demonstrated. Here's our atria, the right atrium and our right ventricle, and we have here our Kent bundle. That is another pathway connecting our atria to ventricle. So we call this sometimes a bypass tract or an AV bypass tract. Okay. Now it could be on the right side, the left side. There's different types of Wolff-Parkinson-White. We're just going to go over the basics of this syndrome. Okay. Now if you recall, most of the PR interval represents AV nodal conduction. So if we have our PR interval, let's draw a complex out. Okay. This is our P wave, our QRS complex, and our T wave. Now the PR interval represents from the beginning of our P wave up until the beginning of our QRS complex. And most of this represents AV nodal conduction. Okay. So if we now have an accessory pathway that's bypassing the normal physiologic block at the AV node, then it makes sense why we should have a short PR interval in this syndrome. Okay, so what we're doing now is that normally we have our sinus node, we have our internodal pathways that come to our AV node, and it's at our AV node that we have this normal physiologic delay. Okay, and from that we have the His bundle, the bundle branches, the left anterior and posterior fascicles, and then our ventricular Purkinje cells. Okay, so what we have going on here is that we have two different pathways, and we'll look at them in a minute. Okay, we have this one that's coming down the bypass tract and the one that's going down our normal conduction pathway. Okay, so two different pathways going on here. The first pathway is the one in which the sinus node fires, it depolarizes the atria, and then makes its way down the Kent bundle to begin depolarizing the ventricles. Okay, so that's what we were just mentioning, where we have the sinus node firing, okay, and it's making its way down and coming down this Kent bundle. Okay, that's our first pathway. So let's just erase some of this so that we can have it clear. Okay, so again, the first one is sinus node fires and we're coming down our Kent bundle. Okay, so we'll call that pathway number 1. The second pathway is the one in which the sinus node fires, it depolarizes the atria, it reaches the AV node where we have that normal physiologic delay, and after that point the impulse makes its way down the rest of the normal conduction pathway through the common His bundle, the bundle branches, the respective fascicles, through the ventricular Purkinje system, and out to the ventricular myocardial cells. So simply put, our pathway 2, the second one, is our normal conduction pathway, right? Where's our sinus node? And we're pretty much firing down our AV node where we have that delay and down the rest of our pathway. So we'll call that pathway number 2, which is simply our normal conduction pathway. So as you can imagine, if conduction proceeds down the first pathway that has the Kent bundle as an accessory pathway, it will bypass the normal physiologic delay at the AV node and begin to depolarize the ventricles before the ventricles can be depolarized by the normal conduction pathway. Therefore, because we said AV nodal conduction makes up the majority of the PR interval, and because it's now bypassing the AV node by this accessory pathway, we're going to get that short PR interval. Okay, so again, instead of going down our normal pathway, we're first coming down this initial pathway. We don't have to stop for anything. We simply go down the pathway. There's no delay, so we can already start depolarizing the ventricles. Okay, and that's why, remember, the AV nodal conduction makes up the majority of the PR interval. So if we're now bypassing that, we are going to have now a shortened PR interval. Okay, so it will be a short PR interval is one of the main things we'll see on the EKG. Now at the same time, the bypass tract is depolarizing the ventricles before normal conduction, before the normal conduction pathway can. And so we get this initial ventricular depolarization by the accessory pathway, and this manifests as on the EKG as initial slurring of the QRS complex, which is commonly referred to as the delta wave. Okay, so again, we're coming down this pathway, we start to depolarize the ventricles earlier than the normal pathway, and because of that, we start to see an initial slurring of our QRS complex. Okay, and that's our delta wave here. Notice how there's that initial slurring portion. Okay, it's slower because we're not going down our conduction pathway, but again, Because we're bypassing that, we see a short PR interval present here, and we see this delta wave because of that initial depolarization of the ventricles early on. Okay. Now, eventually, the two depolarization waves of these tracts will meet and cancel each other out. It's also important to note that the conduction through the ventricles outside the normal conduction system, as with the Kent bundle, progresses slowly by cell-to-cell spread, which causes a wide QRS complex. However, in this case, we also have conduction down the normal conduction pathway. Thus, we will see initial slurring of the QRS complex representing ventricular tissue stimulated by the Kent bundle, and the remaining of the QRS representing normal conduction. And because the initial portion occurs through the slow cell-to-cell depolarization and earlier, we often see a prolonged QRS interval. Okay, so again, we have the initial slurring because of the initial depolarization of the ventricles by our Kent bundle, okay, and then we have our AV node. Eventually, our normal conduction pathway makes it through and starts also depolarizing the ventricles, and eventually they'll come together and cancel each other out, okay. And because the end of the QRS complex represents normal conduction, you will see that this portion here is pretty much narrow and normal. Okay, the end of our QRS complex is the normal ventricular depolarization. Okay, it's just that initial slurring, that delta wave, that causes this prolonged or widened QRS complex. Okay, so let's review what we could see on the EKG. So we could expect a normal P wave because atrial conduction is occurring normally. There will be that short PR interval, less than 120 milliseconds, okay? And that's due to the presence of the Kent bundle bypass tract in the majority of patients. It's also important to note that about 12% of patients actually have a normal PR interval, okay? So something to be aware of. Now, we said there will be a wide QRS complex greater than 110 milliseconds in the presence of that delta wave, okay? That's really characteristic. And that's due to early ventricular depolarization down the Kent bundle. In addition, we may see ST and T wave changes or abnormalities. For instance, we may see discordant ST and T waves, changes in which the ST segment and T wave are directed in the opposite direction of the main QRS complex. Now, WPW syndrome is also associated with paroxysmal tachycardias that are typically wide, could be regular or irregular, and are very fast. Now, one thing to note is that if we have all these EKG findings we discussed without tachycardia present, then this is referred to as a WPW pattern, okay? And lastly, the distinction between supraventricular tachycardia and ventricular tachycardia can be difficult. Therefore, you should treat a wide complex tachycardia as VTAC until proven otherwise. Okay, so let's just go over those EKG features. So again, we have a regular rhythm, okay, during this during WPW syndrome, okay, unless we're in like a flutter or a fib where we'll have an irregular rhythm, okay, and that can happen. In that case, we can have these tachyarrhythmias that occur. But in sinus rhythm, it should be regular. The rate should be between 60 and 100 beats per minute in sinus rhythm because that's what the intrinsic rate of the sinus node is. The P waves will be constant, normal in morphology, okay. The P to QRS ratio will be 1-to-1, okay, and we'll have in typically short PR interval, less than 120 milliseconds. The QRS interval will be prolonged, greater than 110 milliseconds, with the delta wave present, right, representing that early ventricular depolarization down the Kent bundle pathway, okay. There will be no grouping and no drop beats. Now, it's important to note the difference between WPW syndrome and something called Long-Ganong-Levine or LGL syndrome. Okay, and we'll do a lecture on this, but just so you were, LGL syndrome, there's a bypass tract that's known as the James fiber that bypasses the normal physiologic block of the AV node. However, it then continues down the normal conduction pathway. Therefore, with LGL syndrome, we will see a short PR interval because we bypass the AV nodal conduction, but we won't see a wide QRS complex or delta wave because we continue down the normal conduction pathway, okay? So just so you're aware, and we'll do a lecture on this as well, okay? But this, so in this case, we have this Kent bundle in the right here, okay? And because we're bypassing the normal conduction pathway, we not only get a short PR interval, but we get that slow initial slurring, which we call the delta wave. In Long-Ganong-Levine syndrome, we have this bypass tract that comes, we call it the James fiber, and it connects from the atria and just to below the AV node. So our AV node is here and is bypassing that area, so we get a short PR interval. However, it then connects to the normal conduction pathway, and because it conducts down normally, the ventricles in the QRS complex will be normal. especially so we won't have a delta wave present at all. So lastly, LGL syndrome is often benign, while WPW syndrome can be life-threatening. All right, so let's go through our chart to briefly review what we discussed and go over some of these pseudoinfarction patterns that we may see. Okay, so again, WPW syndrome is a ventricular pre-excitation syndrome that's due to impulses going down this bypass tract that bypasses the AV node, and it's known as that Kent bundle. Okay, now normally this is a congenital development. Okay, so people are born with this additional tract, and we can have these characteristic EKG features where we saw the short PR interval and that delta wave. And remember, if they're not associated with tachyarrhythmias, then we call it simply WPW pattern. It's when we have these tachyarrhythmias that we call it WPW syndrome. In terms of the pathophysiology, remember two pathways. We have one pathway that's the normal pathway going down our normal AV node, and the other one is this accessory pathway with the Kent bundle, where we bypass the AV node, we get a short PR interval, early ventricular depolarization, and that delta wave. Okay. Now, clinically speaking, this is potentially life-threatening, especially if it's in the setting of atrial flutter or atrial fibrillation. Okay. There's a small risk of sudden cardiac death. We mentioned that delta wave, which is the initial slurring of the QRS complex secondary to ventricular pre-excitation via the accessory pathway. We could see discordant ST or T wave changes in which the ST and T waves are directed in the opposite direction to the main QRS vector. And now we have these pseudo-infarct patterns. Okay, pseudo-infarct means that it appears as you have an infarction on the EKG, but in fact it's not really an infarction. Okay, and what we see here, if you see these negative delta waves, so imagine these going in the opposite direction, so pretty much negative, okay, they may represent pseudo Q waves, okay, and Q waves, which we'll learn, are a sign of either a prior infarction. So if you see those in the inferior leads, 2, 3, and AVF, or V2 through V5, they may mimic an inferior or anterior infarction respectively. And then if we see prominent R waves in V1 through V3, that may mimic a posterior infarction. Okay, and again, regular in sinus rhythm, the rate will be normal if we're in sinus rhythm, but obviously we can have these episodic tachyarrhythmias that take place. Okay, just remember short PR interval and that delta wave that represents the early ventricular depolarization down the Kent bundle. Well, that's the end of this lecture. We discussed Wolff-Parkinson-White or WPW syndrome, including its pathophysiology and EKG features. I hope you learned something.